Hi, I'm Andrew from Denver, Colorado. I've been on methadone for over a decade and have a couple thoughts about diversion control measures. If policies like call-in lines could be clearly shown to reduce diversion, save lives, and improve treatment outcomes, I would fully support them. But that hasn't been my experience. In opioid treatment programs, many policies aren't grounded in strong, conclusive evidence. Risk is often assumed and not actually measured. And that matters because in healthcare, when something is strict or limiting, you expect there to be a good reason for it. You expect policies to help patients. You expect them to be backed by evidence. And too often, that standard is not being met. If our guiding principle is to do no harm, then we have to ask some hard questions. What is the harm of these policies? And is it greater than the risk they're trying to prevent? Because diversion control is required, but callback lines specifically are not. And there are other ways to meet those requirements without creating this level of burden. The goal of treatment isn't just to control risk, it's to help people build stable, meaningful lives. Treatment should support that and not stand in the way of it. And in reality, these call-in lines are deeply disruptive. You might have to leave work immediately. You might have to scramble to find childcare. You might not even have transportation to get there in time. And then an assumption of goodwill or benefit of the doubt is not afforded. Your daily dose is presented as a privilege to be dispensed only after payment, paperwork, diversion checks, call in lines, camera supervised UAs, and so forth. That might sound reasonable on paper, but in reality, it's not. The consequences are serious. I work a 9 to 5 job, and I'm expected to drop everything and show up at the clinic on demand. And sometimes, after doing all that, I get there and I'm told that the person I need to see has quit, is unavailable, and that I should come back another day. No notice, no flexibility, just the assumption that I have no life outside of treatment. After a while, it stops feeling like healthcare and it starts feeling like surveillance. You're expected to plan your life around the possibility of being called in at any moment. And if you can't, you risk losing take home medication, the very thing that allows some semblance of freedom. And for me, it became death by 1,000 paper cuts. Not one big issue, just constant accumulating burdens. And here's the contradiction. Clinics say you need to be stable to earn flexibility, but policies like this actually make stability harder to achieve. It becomes a vicious loop. Patients are asked to prove stability while navigating rules that disrupt their ability to create a stable life. The real risk right now isn't just diversion, it's failure to treat. It's people leaving programs because the burden becomes too much. It's people never starting treatment because they see what's required and decide they can't live that way. In my work at a local public health agency, I see how methadone's reputation as liquid handcuffs causes would-be success stories to forego even considering it as a viable option for their OUD. This persists despite genuine progress with CFR 42 Part 8. In the context of today's drug supply, that risk is even more concerning. If someone's taking methadone instead of fentanyl, that's a life-saving difference. But policies like this push people away. I'm one of those people being pushed to the edge. After 10 years on a medication that helped me build a stable, meaningful life, I've started tapering off. Not because it's the best clinical decision, but because I need relief from the system. The very thing that facilitated my recovery now feels like a singular obstacle between myself and my potential. Not the medicine, not the MOUD itself, but the OTP framework which dispenses it. And I know I'm not the only one. If a policy leads people to leave effective treatment, then its intention doesn't really matter. The outcome is harm. Call-in lines also undermine something essential to recovery, and that's trust. Patients are asked to prove themselves over and over and over again, even after years of successful treatment. Meanwhile, clinics often have the discretion in how these rules are enforced. In my own experience, I stopped calling in the call-in line months ago, and nothing changed. I still meet all the other requirements, and that alone raises the question. If the policy isn't necessary to ensure compliance, why require it at all? There are ways to meet diversion control requirements that are more flexible, more targeted, and more patient-centered. Ways that rely on clinical judgment instead of blanket rules. ways that build trust instead of assuming the worst. Because what keeps people healthy is not surveillance. It's connection, it's dignity, it's being trusted to continue the progress they've already worked so hard for. And at the end of the day, we have to look beyond what these policies are intended to do and what they actually do. If they're making it harder for people to stay in treatment, harder to build productive lives, and harder to access care, it's time to rethink them. Thank you.